Okay, we're joining Frankfurt at the moment.
Mark, come and have a seat.
Horst? Horst? Yeah, Horst, can you
Okay,
hear us?
welcome back. We have case number, yeah, I can hear you, of course. Case number 13. Jan, please go ahead with the case history.
Our next patient is a 30-year-old female. In April this year, she presented with sudden persistent visual impairment and unsteady gait, which was assumed to be due to an ischemic cerebral event. An ASD with an atrial septal aneurysm was discovered, and no other potential source of the event could be identified. ECG shows a sinus rhythm and a heart rate of 81 beats per minute. Holter ECG and carotid duplex showed no unusual findings. TEE shows a large atrial septal aneurysm and a secundum type ASD with a left to right shunt and a diameter of 7 millimeters. There are no other relevant findings. Back to Professor Sievert.
Okay, thank you. So a straightforward case, but not as easy as I thought, because I could not cross the septum with the catheter alone. You can see here, then I go to, when I'm not able to cross immediately, I go to 30-degree LAO and inject some contrast. Still was not able to get access. Then we changed the strategy and introduced the TE first. So now let's look at the TE. Pusher without color at the moment, please. Without color. Okay, so then the next step I do is to do contrast. And contrast echo, when the sheath is in the groin, I just inject blood in and out. And you can see that there's a big aneurysm, but I didn't see any bubbles going across. So now let's do a Valsalva. So Julia's compressing the abdomen. I'm injecting constantly. Oh.
Sorry.
Okay. Okay, now it's releasing. And there are actually a few bubbles appearing there, but I'm not sure. Busha, would you like to comment where they come from?
So can you see flow? It looks like there is some bubble appearance coming from the left veins. And if I try and come round, she doesn't. I'm afraid the imaging isn't very good at that region, but there seems to be some kind of flow coming through. But we have seen some color on the septum now.
So I stop here with the contrast.
Yeah, there you go. Horst, is that helpful?
Mm-hmm.
Can you see
Horst,
a little
stop
bit
there.
of...
Stop there. John, Carol,
Here.
are you still...
Yeah.
John? Microphone? What do you think?
Well, there's got to be
procedure?
something there. I like
mean,
to see the color flow.
Why are we looking so hard? All of a sudden. We couldn't see anything on color.
No? There.
Ah, there we go. You found it. It wasn't there before. I got the answer.
Yeah, we showed you without color initially here.
So why are you having difficulty finding this, Horst?
Yeah, I don't know.
You're not trying hard enough.
We couldn't see the hole.
Horst,
Yeah.
just...
Exactly. Not enough experience.
May I say something?
Yes,
Yeah.
It was
Sure.
clear cut, I think, the negative contrast at the beginning, at that point. It was clear, I think,
Was
the
it clear?
negative.
Let me give.
it's close to
Let
the
me give contrast
SVC,
again.
so...
So I'm not sure whether I could get enough contrast up there. It's hard to say because you can also have inflow from the superior vena cava because the contrast is injected via the femoral vein. So it's hard to differentiate, but you may be right.
Horst, may I ask you, if you see,
Yeah.
if you see a clear left to right shunt with a color Doppler, why you're doing this contrast medium? This is a wasting of time.
No, actually, I start always with contrast because when I cannot cross a defect initially, then I'm thinking about, well, there may be no defect. And the best test overall, whether there's a shunt or not, is contrast, because then you don't have to interrogate the whole septum. You can just focus on the aorta. If you don't see bubbles there, then that usually means there's no shunt. But I mean, this is a good example that there's no rule without exception.
But if you see
But still, I'm not able to go through.
But
Yeah.
if you see a color flow jet, there must be something, and even though there is no contrast medium on the left side, so for me it is
Yes,
again,
but it's
wasting
more
time.
difficult to go through the whole Felix, it's more difficult to go through the whole septum, especially in a patient with septum aneurysm, and to rule out an ASD. Usually contrast is faster. Again, this is a good example that there's
Horst,
no
we
rule,
disagree.
no exception, but
We disagree with you about that, but are you going to try and... Why don't you just go like you're doing a transeptal, come from SVC, come down and...
Gareth?
Yeah, I was just going to say, it's tricky
That's
to
what I
get
tried,
the
yeah.
Valsalva with right to left shunt's tricky when you're lying on the table in the cath lab. Did you have a pre-procedural bubble study with a proper Valsalva that showed there was a right to left shunt?
well, the patient is not in general anesthesia, so usually the Valsalva is pretty good, what we can do here. We had a prior TE from outside, but many of the TEs we get referred actually are, they describe bubbles and there are no bubbles, so it's sometimes difficult. And we don't, obviously, we do not repeat the TE before we bring the patient to the cath lab here. Now let's, Busha, can you show me the catheter in relation to the septum? Can you see me? I'm now using a right coronary.
Was the bubble return significant from the veins, the left veins? She said there was bubbles from there.
It was very small amount of bubbles, Busha, right?
Yeah, very small. And I wasn't sure, it may well have been this defect it's coming from.
Get your hands out of the way, whoever's got their hands in this.
Horst?
Not the patient, yeah.
See you, Horst.
Yeah.
Horst, there is one simple trick. If you have a second venous access and push a second guide catheter against the fossa ovalis, then you can stretch the whole aneurysmatic part towards the left atrium, and that opens up that perforation at that upper part, which is sometimes much easier to probe then.
I don't think you need that.
It's a
I
good
think
idea.
you need to get
Yeah.
you just need to get your catheter into the SVC, and the reason you can't is because that aneurysm, no, you're still not in SVC. I think once you get in the SVC and you
Busha,
come
where I
down,
am?
you'll get
We're
it.
looking for you. I can't see you, Horst.
No, because you're
Where
not.
are
Okay,
you?
check the SVC, whether I'm in the SVC now or
Yeah.
not. I think I am.
So the ASD
Yeah, I
is
can see you
pointed
now. There
up
you
toward
are.
the SVC. That's why it's a little difficult to cross from below.
Yeah.
Your comment, Neil, about like a transeptal makes a lot of sense.
So there you are in the SVC coming down slowly towards the septum. So you should be very close to the defect there.
Is the wire through now or not? No, it's
You're
not
miles
through,
away
no.
from it.
No.
You need to get to
No,
SVC.
the
Thank
angle.
you very much.
Yeah, so
Let's,
Horst, can you see that view there?
let's
Your
leave them for a
wire is,
couple of
you're
minutes.
pointing in the wrong direction. So here's your wire, but the PF, you need to come here. You
Yeah.
need to come round the aneurysm and find your way.
So, Jacques, do you agree that I'm in the
I want
SVC
to-
now?
Let's carry
Yeah,
on with
you're
our-
there.
Yes.
This is the
Do we agree?
SVC, and you're here.
Yes, okay. So it's clearly the SVC.
And you're right on the defect there. Right on the defect.
Neil, can I make a comment?
Actually, I'm...
Bharat,
Sure.
go ahead.
Yes.
Yeah, no, the comment I wanted to make, I think that you come from the SVC, but don't use the wire. Probably entering only with catheter may be a good idea in a case like
I'm
this.
inclined to agree with you, and I don't think he's high enough in the SVC at all there yet. But
Okay, now, Neil, because you are constantly tugging on that, Busha, can you show me the catheter on TE now? Okay. Now, you see it's clearly in the SVC.
no,
Can
I
you
don't think
admit
you
that,
are.
please?
I think the
What is that?
yeah.
What is
but,
that?
But that's not the tip of the
Bush, I'm showing
catheter.
you.
This is the tip.
No, I disagree.
Yeah. Now
It's
you
not
see
the
the
tip.
catheter
This-
there.
I
Just
what
can't
is
see
that?
it beyond that point, so
No,
that looks like
it's
the
not
tip
the
to
tip
me.
of the catheter. It's the you've got
Okay.
a little
Well, I'm
angle of
turning,
it.
okay. So I'm turning the catheter around. Busha, can you focus on the tip of the catheter again?
If I can. Yeah,
So
so
you
just
see it's
following it up.
clearly the tip. You see actually the bending of the catheter.
And there's the tip here.
Yeah.
So,
I'm
There.
rotating now.
yeah, so are we
Horst,
convinced
you-
it's a tip now?
Horst,
Okay,
usually you
good.
say that you can cross any hole in the atrial septum at always,
Yes,
except
I will.
yes.
Yeah, I will. No, I'm just wanting to give Neil a rest here, so because he was pushing me.
Well,
Send him for a tea now.
I still don't believe
Okay,
that
so
was
the
a typical
suggestion
case.
was to cross with catheter. It will. I tried that before, so it will not cross the catheter alone. Again, this is now a right coronary catheter, not a multipurpose. The multipurpose has an angle which is not good for this hole here.
Did you try the multi-purpose, Horst?
Yes,
Oliver?
and the reason why it did not cross is the angle.
Yeah, I would use an IMA catheter for this.
IMA. All right.
IMA.
IMA may be better, yeah. Yeah, I agree.
Because it's almost you want
Okay.
to look down on the hole
We'll let
from
you struggle
above.
with that.
Yeah.
Let's. I just want. Can we go back? Horst, we're going to leave you for. No?
Yeah, that's fine.
What do you mean we
Yeah.
can't contact?
Okay, Horst, we're back live with you. You seem somehow to have accidentally crossed the hole.
Yeah, I could not prevent it. I pulled on the catheter, but it just went through. So finally, it was
how did you do
the
it?
IMA catheter, IMA catheter with a wire. Diagnostic IMA, mammaria catheter with a wire.
Good suggestion from Oliver.
Absolutely, yeah.
We should have sent him over there in the first place.
Yeah, but he didn't want to come.
And I suppose now you can't find the pulmonary vein with this catheter.
Exactly. Okay, let's go then with the, let's just make a loop in the LAA, in the left atrium. And actually, what is the diameter of this defect? It was
5 by 4 millimeters. Just go back.
Horst, we're going to. We
0.4.
can come in and out of you easily, but we really need to move on with some questions and
fine.
lectures. We can
That's
see what
fine.
you're doing, so good luck with that.
Yeah. Okay.
Horst, we're with you now.
So we crossed the defect with an IMA catheter. Then let's switch to the echo. Busha, what do you see there?
So just to remind us, this is the defect that we were looking at, and then so Horst crossed the defect accidentally, as you said, and it shows you how interesting this image looks, because it looks like the wire is crossed quite inferiorly on the septum. Any comments on that?
Yep, that's well.
What do you think? What is that?
Well, this is the advantage of 3D, isn't it, now? This is the
Busha,
published
go
advantage
on.
of 3D.
Okay, and then we're ballooning now, and I'll just show you our picture here. So this is a balloon up there, and then our measurement, which is approximately 4-5 millimeters.
And now you can see that the balloon is very close to the septum secundum. So we are not crossing an inferior defect. We are crossing the defect we have seen on the TE before.
Yep.
Without needing
And you'll see-
three-dimensional echo.
Exactly, we don't need that. But nothing against 3D. But the best way to differentiate this is to turn the echo probe and look whether the wire is touching, or the balloon is touching the septum secundum. Then you know they have crossed the PFO, not an inferior defect. Okay, so
Horst?
we will close this. Yeah.
Horst, for me, it seems that
Yeah.
it is a separated defect, and you are probably just in one part of this defect, because it seems a bit bigger in the echo than it is really measured with the balloon. So
I have a
Okay,
comment?
with the balloon we measured the diameter of 5 and of 4 measured on echo. So let's go to the TE again, and now go to the long axis view and slowly rotate the TE probe, and then you will see that it is going through the PFO.
Yeah, this
There.
is exactly what I thought. And Horst reassured me he'd gone through the right hole, and he's absolutely right. Because as you see, as I rotate up, this is the hole we're going through. I'll just see if I can find that a bit better for you.
So this is a common phenomenon, what you see in patients with a PFO and big septum aneurysm, that it looks like you crossed an inferior defect, but you didn't.
Yeah.
So now we have the, we will close this with a 25 millimeter Occlutech device. Let me just show you how to mount this here. Can you advance the little hub? Okay.
So I have a
So
question.
there's a little
Horst,
ball. Yes, go ahead with. Yeah.
Horst, I have a question. Can you
Go
show
ahead.
the balloon waist where is the waist of the balloon when the balloon was inflated? I think you are not through the same hole which was shown by color flow on echo. I think there is a second hole because the waist of the balloon is way too inside the left atrium when you inflate the balloon. So
here's
it's
the image of the balloon inflated.
yes.
And I do appreciate what you're saying because this is exactly what I thought.
Yeah.
I'll just show you some 3D images. So this is with the wire through, and Horst was pulling the balloon back, and it just got caught on the opening of the hole. And you can see clearly that this hole is superior and posterior, which is where we found it. So I'll just put this in the correct view. So can you see here that in this image that here's the fossa in front of us, here's the mitral valve, right upper pulmonary vein will be in this direction. This is your wire coming through and then going into the right atrium behind. This is the aneurysmal septum, and this is the defect. So this is the defect up here that we saw, which was quite superior by the SVC, but very posterior. So I absolutely thought that Horst had gone down here somewhere, but actually he hasn't. He went through the original hole, and we confirmed that on color as well.
So now let's look. I'm deploying the left atrial disc, and this will also help to make sure where we are.
Horst, so you chose a somewhat larger device to stabilize that aneurysm, yes? Because otherwise,
Yeah, a little bit, but
formally-
the intention is not to stabilize. The intention is not to stabilize it completely, because that is just too big to be stabilized. Okay.
25, because
Now
otherwise you could
focus on the
have
septum,
used
please.
a smaller device.
Yeah, but yeah.
I'm happy you're using a 25 personally, but it was just a point I was making for discussion.
Here. Septum long axis, please. Okay. Now the device, I turned the sheath to the right side of the patient, and I'm pulling back now. You see how flexible that is when it's partially deployed. The patient is getting nervous a little bit here.
Well, I was
Okay, so
wondering.
I'm just now you see that the device is grabbing the septum secundum, which is another confirmation that I'm not crossed inferiorly.
Yeah, exactly.
Yeah.
Quick, let it
So
go,
turn
Horst.
around the echo
I can't
probe.
take any more.
Yeah, we let it go.
What do you want me to do, Horst? So show you the
Okay.
different views?
So I'm releasing it now. Okay, final check with echo, please. And then you can go.
So color compare. Yeah. So we're just going to quickly look around here, starting, normally the checks start at 0 degrees. Septum's looking very bouncy, but the device itself is looking very nice. Its position and apposition look very good. We just
That's
look at it
great.
in 50 degrees. Looks good.
Okay.
Yeah, this looks nice.
So Zaid, are you happy
Okay,
with the
thank you
device
very much.
position
Go
and the
back
holes?
to India. This was one of the
Hold on.
easy, straightforward PFO.
It would not matter
Thank you, Horst.
since you are very close to the defect. Even if you're through inferior hole, it doesn't matter. The device would close all of this 25. The point was that if you are not to the correct hole, one edge of the device can actually go through this hole and cause a residual defect.
Okay,
A
Horst?
month later.
Thank you.
Okay. Thank you very much.
Thank you.